Testing, testing. All right, you're on.
All right. Thank you for joining us, both in person and online, for this talk. Thanks again for the University of Maryland, the Institute of Human Virology, THRIVE, Jacques, for inviting me to give this talk for another year, and to celebrate Pride Month, and to allow actually for us to be able to openly speak about these issues. Next slide. Great, so I have no financial disclosures. I do think that when I'm giving these talks, I like to also say and state, acknowledge my personal privilege of being a cisgender man, and the need to use our voices to elevate the voices of other people who are underserved, notably in our LGBTQ plus community, transgender and gender nonconforming individuals. Slide. So the poll question is, poll questions are a little bit to let us know who's in the audience, but also to make sure that the poll system is working for the first couple ones. So yeah, where's everyone in the webinar or in person or online joining us from? Here are your options. Maybe let me know.
Looks like we're set. I believe it 5 seconds.
Okay. So, oh, it looks like, is that the age one?
Yeah, I think we're seeing the age.
Oh, I'm sorry.
That's okay. That's okay. Actually, we could just turn into the page.
Okay.
Age, no worries. Okay, great. So most people are 25 to 45, well, 100%. Okay, good. What is our next question? What is your sexual orientation? And here I also would like to preface that this is all very confidential. You know, no one can see our answers. We could just see the clustered answers. Similarly with the questions, throughout the presentation, you're welcome to write in those questions in the chat box, and no one can actually see them. Okay, great. All right, so we have some people, and one more question on gender identity with the options listed. Great. Okay. And one last question about who is in healthcare and who's not. So do you work in healthcare? And I guess we're defining it as providing services. Do you provide healthcare services? Yes or no? Good. Okay, I see a split, half and half. Great. Okay, so with these questions, now we know a little bit about the audience. So I think it's a little bit, I like the fact that we have a mix of people from the healthcare community and people from the general community. The goal today is to learn about really sexual health practices for the community and be aware of resources that are available for LGBTQ plus individuals, particularly that are resources that are affirming and that are sex positive. Also, it's important, I think, to highlight here to know when to seek medical attention and know what aligns with your personal goals. I hope that healthcare personnel, regardless what you do in the healthcare setting, would get tip on how to engage and listen to patients when it comes to sexual health. Slide. Great, so I will not discuss these heavy topics today, although they are very important and relate very heavily to our talk. So I will not discuss the unfortunate events of last Friday where the Supreme Court overturned Roe v. Wade, and obviously its direct and indirect impacts on LGBT health and LGBT rights, but also we will not talk about the sweeping legislation around the US that has been affecting not only LGBT rights, but also specifically LGBT and transgender health on different jurisdiction levels, and the rise in homophobia and transphobia. An example is even just while we're publicizing for this event, we're still getting comments on social media that were quite homophobic and transphobic. So And I think this is like a small picture of what's happening on the national front. Just something to keep in the back of our minds. What we will not be going into too much details about all of this. Right, so we'll start off by introducing some terms just so that we're all on the same page. We'll talk about healthy sexual practices, sexual health maintenance and cancer screening. And I am an infectious disease provider, and I feel like we're also talking about our infectious disease clinic. So we're going to give a good weight to talk about sexually transmitted infections prep and HIV care, although it won't be the only focus of the talk. So let's define some terms. I'll start off by saying the whole talk is going to be focused on a sex positive approach, which is the approach we also follow in our clinical practice at THRIVE at University of Maryland. So we do not have any shaming to any sexual practices. Of course, we respect and appreciate all sexual and gender minority communities. I talk about this gender unicorn available actually on the TSER, Transgender Student Educational Resources. Really a great resource for people who are interested in learning about gender identity, and with a lot of great infographics like this one. But the focus here is to notice that these are all arrows. There's no boxes that we're defining. We're talking in arrows. So there's a spectrum. And people can be anywhere on that spectrum. And within each category, there's different options. And I guess with each option, you could be on different parts within each option too. So let's talk about gender identity first, right? That's how you're identifying internally. How do you perceive yourself to be? And this can be defined as early as 3 years old. And people can be, again, anywhere on these arrows from female, male, or other genders. This can also vary with time. It's not written in stone. So that's another thing to keep in mind. Gender expression is how we express ourselves outwardly towards society. And so those two don't always overlap, right? And then gender expression, a lot of it is social constructs. So what is feminine and masculine, for example, in the United States, may be different in other Native American communities, for example, or also maybe different in India or in other countries. So while maybe wearing a skirt in the United States is considered to be feminine, that does not apply everywhere. So it's also, I guess, region specific and culture specific. So that's feminine, masculine, and other, and you can be anywhere on all of these, this spectrum, these arrows. Sex assigned at birth, really controversial about how do we set that at birth, but usually there's female, male, assigned at birth, and other and intersex. Some of this is related to chromosomes, others related to biological factors. So there's a lot that goes into this. The way it is defined in a lot of our medical communities, we could talk about for hours, but will not be the focus of today's talk. So with just these three top parts that we're talking about, sex assigned, a transgender person by definition would be someone who is sex assigned at birth is different than their current gender identity. Similarly, someone who's gender nonconforming could have whatever sex assigned at birth, but they do have a gender identity that falls nowhere on any of these spectrums, right? Then the bottom two parts are physical attraction and emotional attraction. I would add maybe like a third section there to talk about sexual identity. And that's where how sexual orientation can really be defined with this triangle. And so physical attraction can fall anywhere also. Someone can be attracted to women, men, or people of other genders. And similarly, emotional attraction can be to women, men, and other genders. These terms are of gay, bisexual, and then there's a long list of terms that we will not have time to go in. Although there are great resources that we could share with everybody later on to understand these terms. But I'd say someone who's gay is someone who's emotionally attracted to people of the same sex or gender that they identify as. And that's where actually the sexual identity section comes in. Someone can also identify with a certain community. So you can identify with the gay community, you can identify with the bisexual community. Slide. So stigma and discrimination in healthcare. I guess this is an important part to talk about at all times when we're talking about LGBT health. notably sexual health. So obviously LGBTQ plus individuals face discrimination in healthcare. On one side, we have people who, full blown get refused from care, get kicked out of clinics, could say you're not welcome here, right? That's the most extreme side, but others indirectly. Someone can get misgendered, someone can have assumptions made about who their partner is. And that obviously is kind of an indirect kick to someone to say, I'm not comfortable coming back to this clinic, right? I'm not comfortable in seeing this provider again. And then there's the perceived discrimination. So if you hear your friend saying, oh, I was not welcomed in this clinic, or this happened to me in this clinical setting or in this emergency room, then you're going to be scared of seeking care altogether. So that's all of that layered together, you get into worse health outcomes. We know this from what we call the minority stress, all the way mentioned here at the bottom, even multiple minority stress. So you could face discrimination. You could also face discrimination for maybe identifying as a racial minority. And therefore, you're facing racism from within your own community, from LGBTQ plus individuals, but also sometimes facing discrimination from the public, whether it's in the society, whether it's in media, whether it's from your family members, your own other members of your community. And all of that layered together can lead to worse socioeconomic outcomes. You can't get a good job, you don't have good housing stability because of who you are. And then the last part that adds on to that is your health. So your mental health can struggle, higher risk of having HIV, acquiring HIV, higher risk of maybe engaging in survival sex work in certain cases, and higher risk of substance use. The list goes on and on, just something to kind of put everything into frame when we're talking about sexual health.
Thank you.
All right, so let's get into healthy sexual practices, starting off with consent. And I think the concept of consent obviously has become much more publicly spoken about, notably after the Me Too movement. But kind of a highlight too, that within our own LGBTQ plus communities, we can have issues of consent that come into play. And this has been down-regulated for the longest time. So for a long time, we've had people say, well, this community cannot be a victim of sexual assault for really. And so one, that's a myth that obviously should never be acknowledged. Consent should be in every sexual practice. On top of that, I'll talk about recognizing personal boundaries. Sorry, other slide. Yeah, recognizing personal sexual boundaries and sexual pleasure. So what does that mean? It means communication is key, I think, before any sexual practice. Talk to your sexual partner. This is something that's in a lot of times disregarded, ignored. Communication to say, this is what I like, this is what I don't like. And then I think that therefore consent comes into that conversation as well. Mind-altering substances can obviously affect your judgment during sexual practices. So know your limits, I guess, is rule number one. And rule number two, have someone out there with you to see if they can help you. If you have a friend with you who's going out, to just say, have I reached my limit of, or can I make sound judgments? I put in a resource there about Be More Safe, an app that is available for survivors and victims of sexual assault, connected to our colleagues at Mercy Medical Center and their emergency room. So an emergency room specifically that has a whole program on survivors of sexual assault, with connection also to post-exposure prophylaxis, HIV post-exposure prophylaxis, or PEP programs through THRIVE. But you could get a lot of those resources through that. We know that sexual assault can be very heavy, very traumatic, and seeking care can sometimes be a barrier, but just know that this is a great resource that you could seek whenever you're feeling most comfortable. So another part is, so sexual practices can vary. Obviously, different things are right for different people. We're not going to talk about all kinks, but people discussing, again, going back to that communication piece, to know what is right for you and what your kink is, and maybe someone else you're talking to could have that same that same preference. Use of barrier protection, obviously very important to mention with non-monogamous partners, whether it's condoms, dental dams. We'll talk about this more when we talk about sexually transmitted infections and prevention. But lubricant is where I would focus most of the comment here, whether it's with anal sex or penis to vaginal sex, or even penis to front hole or neovaginas that transgender individuals might have. Lubricant always comes into making sexual practices much more easy, much more tolerable, and sorry, not tolerable, much more easy, particularly when it comes to anal health. And so it's known to prevent fissures, hemorrhoids. I get a lot of questions about all of these lesions that can happen within the anus. Similarly, I get a lot of questions about douching and prepping for anal sex. Knowing just that excess is not what you want to, excess is not your friend, and then lubricant is your friend in during sexual practices. Obviously though, if you have any lesions, any concerns that you're worried about within the anal canal, you have to talk to your doctor about them. And that brings us to the last point, have a healthcare provider that you could comfortably discuss your sexual practices with. And we'll get to a long list of how you could reach those healthcare providers. But if your current healthcare provider is someone you're not comfortable talking with, revisit that discussion. If it's someone you just don't feel comfortable with, then you should find a new healthcare provider. Thanks. Okay, so a word on sexual health in transgender and gender nonconforming individuals. Although the whole talk is going to discuss this topic throughout, just a couple points to highlight. One, not everyone who is trans will seek gender affirming hormones or gender affirming care or gender affirming surgeries. So how someone defines themselves is how someone's gender identity is defined by them only and not by the medication or the surgeries they take. If seeking surgery, and in case of vaginoplasty, we said lubrication will still be needed, and a lubricant in all sexual practices as a general rule. But also reproductive health discussions are important to be had with anyone who's transgender nonconforming. So either have those discussions with your healthcare provider. If you are someone who provides gender affirming care, you should be aware of those discussions. Someone who produces sperm can still make someone else pregnant. Someone who has a uterus can still themselves get pregnant, even while on hormones. So that's something to talk about. And then it may take months after surgery, vaginoplasty or phalloplasty, for example, before being able to have penetrative sex. Not that all sex is regarded as penetrative, but within that particular area, it takes time for the tissue to heal. Next slide. Okay, going back to some poll questions. This is to test a little bit the audience's knowledge. Out of the following individuals, who should consider anal cancer screening? I know this is a little bit of a topic that not a lot of people know about. So I'm interested to see how will people respond. Hey. All right. 100% have the same answer. Great. Okay. So we'll get to that answer in a little bit, but we're going to talk about health maintenance and cancer screening and sexual health maintenance and cancer screening. So general rule, if you still have an organ, it needs to be screened. Okay, so cervical cancer screening in anyone who has a cervix, with a note here that lesbian, bisexual, cisgender women are some of the populations epidemiologically that we know are the least likely to get cervical cancer screening. So anyone is at risk, you need to get pap smears. The other population I think of here is transgender men who still have cervixes. And the reason they're being, obviously it can be very uncomfortable to get those pap smears, but there's now different options to discuss with your healthcare provider. I know at University of Maryland, we have a gynecologist who's very trans competent to offer these pap smears. But on top of that, there's also different options of doing self-collected pap smears and only to seek next step or colposcopies in case of an abnormal result. So that's an option for people who are uncomfortable really going to do the full pap smears. Then there's breast cancer screening for anyone who has breast tissue. So that's transgender women after 10 years of being on hormones, transgender men even if they've had top surgery with any residual breast tissue. Obviously, cisgender cisgender women who are lesbians or bisexual, still you are at risk for breast cancer. Anal cancer screening, we've had more information come within the last year about what is the ideal population to screen. Hopefully this will become clear guidelines for everybody. The way I think of it is anybody who is older than 30, if they identify as, if they're men who have sex with men, gay or bisexual, or transgender women who have sex with men. And all that population, the specific population that's at risk is people who are living with HIV. So that's something also we take pride in offering at our clinics. Additionally, we do have women who are living with HIV if they've had any history of vulvar cancer, warts, any HPV-related disease, and we'll talk a little more about HPV in the next slide. Similarly, men who are living with HIV, both of those categories older than 45, at age 45 or older. And then there's a category that I would say plus or minus is men who have sex with men or transgender women who have sex with men who are HIV negative. So that's another population to keep in mind for anal cancer screening starting around age 40. So HPV can be transmitted by skin-to-skin contact. It's very common. A lot of people have already been exposed to HPV. We do think of it as a virus that can be transmitted sexually as well. It is the primary cause for warts, but also can cause different types of these cancers that we talked about. Anal cancer, throat cancer, cervical cancer, penile cancer. Some of those don't have screening tools like throat cancer and penile cancer. We do have screening tools for anal cancer and cervical cancer, as we just mentioned. Luckily for HPV, we do have a vaccine that works. The earlier it's given, the better it works. So vaccinate people young, early, even within the early days of adolescence. Anyone up until the age 26, however, the vaccine is still offered, and you could still be eligible for the vaccine up until age 45. And that applies for all genders and all sexual orientations. All right, another poll question. Among the following symptoms, which should make you seek attention to get screened for STIs or sexually transmitted infections? So I'd like to preface by saying we're going to talk about infections starting now, but this should not be the full focus of your sexual health. Okay, a little bit of a split. Go to the next slide to say, we'll get the answer for that in a little bit. Okay, so I would say with sexually transmitted infections, just like everything we talked about, at THRIVE, at all of our clinics at University of Maryland, with JOCS, with all of our different clinics, we adopt, again, judgment-free approach. No stigma around STIs. If you are diagnosed with an STI, you should get tested, you should get treated, you should disclose to your partners, and you should abstain from sex for 7 days, okay, to avoid transmission of the STI back and forth. But that being said, this is not the case in all of our healthcare communities, and it's not the case in all of the LGBTQ+ community. So just kind of taking a general approach to fight this stigma against STIs, words like clean should be avoided from both healthcare personnel and people in the community. So that being said, everyone who has sex is at risk to contracting an STI. Barrier protection does protect from most STIs. Viruses like HPV or herpes can be transmitted through skin contact, but a lot of the other STIs can be prevented through condoms, dental dams, what we had mentioned earlier. Screen all sites that are used during sex. And so that's a message supposed for community members. Talk to your provider about what sites are you using for sex. And then healthcare providers, you should ask what sites are used for sex to know what to screen. So we know we have clear guidance on testing for the throat, testing of the rectum, and testing of either urinary tests or vaginal swabs for people who have vaginas. We don't have clear guidance on testing of neovaginas in transgender women, but that is something that hopefully more research will come out of in the next couple of years. So what are some symptoms, right? That goes back to our poll question. Most people are asymptomatic. So if you are sexually active, you should get screened once every 3 months as a recommended interval, just because you may be carrying an STI and not know it, okay? But other symptoms should make sure that you do seek not only screening, but sometimes also testing and treat. So not only testing, but also treatment empirically in some cases. So for discharge from genital organs, rectal pain, rectal bleeding, pain on urination, testicular pain for those who have testes, and painful rash or ulcers. An important note there is sometimes people get treated, get tested, maybe don't follow up on their tests. Most importantly, can still have some of these symptoms after treatment. Go back and talk to your provider in that case, okay? So don't hide that, don't feel ashamed to ask again. There might be some other sexually transmitted infections that were not tested, simply because that's something we just seek secondary testing for. I talk about hepatitis briefly within sexual and gender minority communities. Notably, the most common outbreaks that we see are in men who have sex with men, common also in those who practice anal sex in general. So we've seen outbreaks of hepatitis A, B, and C. Guidelines say test yourself for hepatitis C if you belong to this community at least once a year. Luckily, we have treatment that are curative for hepatitis C. Get vaccinated for hepatitis B and A. Check for your immunity for hepatitis B. You probably have been vaccinated as a child, but sometimes that can go away. Hepatitis A, you'll just need that one-time vaccine, but that is important to make sure that you are protected. And then get tested if you feel like you're having any symptoms of hepatitis. Jaundice or yellow around your eyes is one of the most common symptoms. Diarrhea, other symptoms can also present. All right, a word about monkeypox. I'm not going to go into too much details. I know this is a hot topic in the news these days. This is what I could gather as of Friday. About 130 cases of monkeypox have been confirmed in the United States, and the majority have been among gay, bisexual men and other men who have sex with them. Okay? Before I continue talking, I would say it's okay to take a deep breath here and say, oh my God, another thing that I have to worry about, and that's fine. The goal is not to have people worry about another infection, worry about another epidemic, pandemic, whatever. It's most importantly to recognize what is going on in your body and to seek care when needed. But also it's okay to feel overwhelmed sometimes and to talk to your provider about it. So most of the cases have been limited, okay? The symptoms are symptoms of a rash. We're going to show a couple photos in the next slide. They can mimic other sexually transmitted infections like herpes, like a secondary syphilis. So that's something for healthcare providers to keep an eye out for, notably in this community. And they can also coexist with other STIs. Just like we talked about all the other STIs, shame-free when we're addressing monkeypox. If you do have some of these lesions, seek testing that is available. Transmission happens through skin, contact with open lesions, body fluids, less so through droplet transmission. So although it can be transmitted through droplets, this is not like COVID, where transmission is much more likely to happen through droplets. It could also be transmitted through sharing of bedding or clothes. So I guess that's another practice to avoid. Not that, and even the CDC has not issued any guidance on avoiding sex altogether. It's just to be cautious and careful and to look out for any of those lesions that we're going to show on the next slide. So these are what the lesions look like. Sometimes you'll get some redness. This definitely can be harder to see on people of darker skin colors. And then there's raised papule or a raised fluid-filled like pimple, almost like, but they're multiple. They are gathered in different areas. It could happen in the genital area around the anus as well. And I said I'm not going to go into too much details, but I will give this recommendation to go to the CDC website. They have a great reference for people of the community as well as for healthcare providers on cdc.gov/monkeypox, just so that you know who to test. Great. And then one word about meningitis as well. Luckily, we have a vaccine that prevents meningitis. There has been recently an outbreak reported in Florida among also clusters of gay and bisexual men, other men who have sex with men. Please get vaccinated if you belong to this community. The recommendation currently stands: if you're going to Florida, get vaccinated. I say if you belong to this community, talk to your provider about getting the vaccine for meningitis. All right. Think. How often should someone who engages in penetrative sex, and this is penis to front hole or vagina, with multiple partners get screened for HIV? I'm doing the time. Good. Okay. All right, we're getting more of a split here. Answers good. To make some of the questions a little harder. Okay. All right, so we'll get to see the answer here is going to be once every 3 months, and we'll talk about why. So today is not only we're reaching the end of Pride Month, and we're happy to do the celebration for that, but also it's a National HIV Testing Day. So encouraging everybody to know their status. If you've never had an HIV test, get one today. Why not? We are offering HIV testing here at our event for those who are in person. We'll provide some resources at the end of the talk about where to get tested for those who are online. And then get tested every 3 months for people who have multiple partners. I preface that in certain settings, and I feel like this is a practice I apply for my patients, to get tested once yearly for anyone who is sexually active, regardless of who your partners are. And then a window period that is becoming shorter and shorter with newer tests. We are using 4th generation or the most advanced antigen antibody test here. So that is about 2 to 3 weeks. A window period is the period between the time you are exposed to the virus or get infected with HIV and the time where the test will turn out to be positive. Slide. I don't know if this question is going to work. Okay. We'll talk about PrEP and PEP, and we'll discuss who's eligible. So another slide that we're happy to have more information about it than the last year is that now we have other options for PrEP. What is PrEP? PrEP is a tool. It's we call it a biomedical tool, or either a medication that can prevent HIV transmission. And now we have an option of either a pill, one pill once a day that is proven to prevent HIV transmission, or an injection. It's an injection that is given once every 2 months to prevent HIV. Both have been very well studied. Both have proven to be to prevent HIV, both in transgender women, cisgender men who have sex with men who are at risk for HIV. Event-driven PrEP or PrEP on demand. Not very well studied in transgender communities, I preface that. And that's when you're taking those PrEP pills, it's not for the injections, for the pills to be taken before a heightened exposure to HIV or a period where you think you might be at risk, and then to continue taking that through that period until afterwards. Again, most of the big studies have been done for option 1 and 2. So the first top two options. Key points: very important to be adherent, to take your pills every day if you are on PrEP, to make it on time for the injection and not to be delayed, to take it any later. There are very few interactions with other medications. So that's, I think it's important for a lot of gender affirming hormones, for example, for transgender individuals, sorry that put off on the slide. It is safe, no interactions with the current options that we have for PrEP. Next slide. So who is PrEP for? Anyone who wants it, really. We'll put that at the end. But one, it's to confirm someone is HIV negative. Do not take PrEP if you're HIV positive. You'll have to get HIV treatment, which we'll talk about. If you are monogamous with an HIV positive partner, that's a population I think of. And then another group is anybody who's non-monogamous. And who engages in behavior that can transmit HIV. So this is penetrative sex, penis to front hole of vagina or anus, or injection of drugs with sharing needles. So again, here just to say, for example, cisgender women who only have sex with other women, not necessarily at risk for getting HIV. However, I would say that PrEP has just been proven, oral PrEP notably for as long as it's been on the market, has proven to be very safe and effective. So that's why really anybody who's asking about it should be explained what PrEP is and should see if they're eligible and to really get it. What do I have to do? So connect with a PrEP provider. We're proud also to offer PrEP here at THRIVE and with Jacques to connect you with any PrEP resources you might need. We offer different options of PrEP. Both the pill forms and the injectable, long-acting injectable forms. You would need to follow up with your provider once every 3 months after you get on PrEP to get tests done. That's a great opportunity to get screened again for sexually transmitted infections, as we have talked about earlier. And then the main role would be to take PrEP consistently and getting the injection on time. So again, adherence is key. Now, PrEP, or post-exposure prophylaxis, is medication that we give for people who think they had an exposure to HIV. So that could be either unprotected sex with someone whose HIV status is unknown, and by unprotected I mean condomless sex. The other section would be someone who maybe shared needles with someone whose HIV status is unknown. Victims of sexual assault is another big category here. So if you engage in any activity with high risk of transmitting HIV and you are not on PrEP, then this is a good tool. I would say the PrEP.me app available can guide you both to get PrEP resources, but also PEP or post-exposure prophylaxis resources. Again, we offer PEP at THRIVE. A lot of these times, particularly for victims of sexual assault, I'd encourage going to the emergency room. Along with all the trauma-informed care you would get there, you would also get connected to post-exposure prophylaxis or PEP resources, with University of Maryland being one of those options. Okay, getting to the last poll question. I tested positive for HIV. What do I do next? Doing great on time, hopefully. Good. So everybody noticing here that we will need to get treatment as soon as possible. So great, thanks. Great. Talking about HIV care as our last section, let me preface by saying HIV is on the rise in our communities, notably Black trans women, other trans women of color, and Black gay and bisexual men account for the majority of new HIV cases. Why is that? There's obviously a lot of background that goes into that. One, there's a long history of unethical practices, right, against not only Black communities in the past, other racial minorities, other people of color, but also LGBTQ plus communities. So in the early days of the HIV epidemic, a lot of times maybe trans women were ignored, and then the epidemic itself was not acknowledged for a long time, which makes people feel very, I'd say, unethically treated, right? People were being ignored. So that can cause mistrust with the healthcare system. And it's our job to rebuild, as healthcare workers, to rebuild that trust. That plays a part into also why a lot of the tools we talked about to prevent HIV are still harder to reach our most at-risk communities. That being said, HIV care has changed a lot over the last decade. While we had a lot of medication that had a lot of side effects in the early days, now we have medications that have minimal side effects, next to none. We have different options. We have options of pill forms. We have options of injectables that could be given once every month or once every 2 months. And we know that starting early for treatment controls the virus, suppresses the virus. In other words, the virus does not, there's no cure, so the virus remains in the body, but it remains in very low copies, very few copies, which we get to unable to be detectable or undetectable with our usual testing forms. And undetectable, now we know, or suppressed, means that the virus is under control and cannot cause as much harm to the body. Talk about that on the next slide. Now, adherence to medication is key in reaching that status. So really, if you test positive for HIV, the next step would be, am I ready to commit to my treatment? And that's okay to have that discussion with your provider until you are, but the earlier you get the treatment, the better. And as I said, there's different options of treatment between pill forms and injections. So why is being undetectable important? Not only does someone who is undetectable have now a life expectancy of anyone who does not have HIV, for people who have HIV to anyone who does not have HIV. So life expectancy rate. Undetectable is also untransmissible. So if you have HIV, but you're on medication that is suppressing your HIV, then you will not transmit it to your sexual partners. And undetectable also means better immune system, protection from infections, low risk for cancer, low risk for heart disease, low risk for strokes, kidney failure, and even better mental health. So really consider getting involved in care and getting engaged in HIV care. I'm gonna conclude with some take-home messages, not only for community members, but also for healthcare personnel. So for community members, communication when it comes to sexual health, know what is right for you, know what is right for your sexual practices, get screened for anal, cervical, breast cancer as appropriate. If you are sexually active, get tested for STIs and for HIV, and consider starting PrEP if you are eligible. If you test positive for HIV, please, please, please make sure you are engaged in care and having discussions with healthcare personnel. For anybody who works in healthcare, please discuss your patient's sexual orientation, gender identity, and sexual practices. People want you to ask them those questions. What the most studies out there say is that people, well, we know people definitely get scared of seeking healthcare when they have assumptions wrongly made about them. Ask. If you are uncomfortable with these discussions, read more about how you can have these discussions more comfortably. And most of your patients, just remember in the back of your head that most of your patients do want you to ask them, but also that you'll be able to provide better care once you know this information. Have signs throughout your clinic that you are LGBTQ+ affirming. Our communities get attached to the smallest flags that we see on some of these clinics, but also if you are putting those signs, make sure you've done your homework to also be able to present competent care. Be attentive to the needs of your patients. Be ready to learn from your own patients. LGBTQ+ health is an area where we don't have a lot of research. A lot more research is needed, but a lot can be learned from patients themselves. So just be ready for that. Meanwhile, definitely still read up about LGBTQ+ health. Hopefully we'll be able to share some more resources when we email participants. Just concluding with a couple slides on resources available, the THRIVE program, the Jacques Initiative, We're very happy to provide HIV care with a lot of providers who are specialized in HIV, Hep C treatment. We also provide gender affirming care alongside HIV care. We offer PrEP, as I had mentioned. We offer mental health care, opioid use disorder care with Suboxone and Vivitrol for opioid use disorder. We have nutritionists, pharmacists, really a big team that is very patient-centric, social workers, employment counselors, housing coordinators, mental health coordinators for anyone living with HIV, a lot of resources. Cancer screening, we take pride in not only doing cervical and anal paps, but also we do colposcopies and anoscopies for people who are in need. Then JOCs, obviously, are community-based programs with home and community-based case management, bringing the care in the community to the patients. Treatment adherence pharmacy, a pharmacy focused on making sure you get to take your medication. Peer support coaches, hepatitis C treatment, HIV, Hep C testing, HIV prevention, both PEP, PrEP, and linkage to whatever resources you would need in either cases. But also a word about UMMC in general. We have specialists from endocrinology, gynecology, and infectious disease who all offer gender affirming care, some gender affirming surgeries, speech pathology, voice training for transgender individuals, a multidisciplinary team, social workers, again, nurses focused on gender affirmation in your goals, and then a trans competent care through the School of Dentistry with this link that we will send to everybody at the also at the end of the talk with resources available to the numbers to call. And then throughout Star Trek, of course, our School of Medicine colleagues who focus on care of adolescents and young adults, both for HIV, STI, treatment, prevention, as well as gender affirming care, actually, too. So, and then resources across the state. I preface Baltimore Safe Haven here as a great resource for transgender individuals of all ages who are needing social support. GLAMA, health professionals advancing LGBTQ equality with lists of providers near you who are LGBT affirming. And there you go, thank you. These are the numbers, our locations. Happy Pride Month and happy National HIV Testing Day. Enjoy the rest of the celebrations, and we're happy to take questions. Again, feel free to submit questions, even if you're in the audience, through the webinar, through the web. We'll have options to also email questions after we send emails to everybody with not only the content of the slides, but also some resources.
Okay, the first question is, what HIV testing are you ordering every 3 months while someone is on PrEP?
Yes, that's a great question. My practice really depends on discussing with individuals, patients who are on PrEP, what are their sexual practices, and it depends on what form of PrEP they're on. If they are on an injectable, so the once every 2 months, I am ordering an HIV RNA test, or that is a test that detects the virus at the earliest stages of infection. If they are on some of the pill forms, again, it's a discussion. So if there was a more recent exposure within the last week, 2 weeks, then I would order HIV RNA tests. Particularly, if, it depends on how adherent they are to their oral medication. If they take the medication every day, or maybe they miss the month. Otherwise, we order the HIV antigen antibody. It's a 4th generation test with a window period of 2 weeks, 2 to 3 weeks. So not 2 weeks.
Great. Another question was, while talking about stigma and discrimination in healthcare, if a new client shared with us that they were discriminated against from another healthcare provider, is there a way for you to report the incident and hold someone accountable?
Yeah, our medical societies do all condemn any
discriminatory practices. I don't think there's actual action that can be taken against them. I think the most important part there is to really discuss with your patients how much of a scar that left on them, and to remove some of the myths that they might have had about healthcare altogether, right? So that they're easily getting re-engaged in care. There are no laws that really punish someone who's provided discriminatory care.
Okay.
To my best knowledge.
Next question, is there a follow-up counseling for those persons who have taken PEP?
Yes, so we do offer follow-up counseling through our Thrive clinic as well, and Jacques will be able to help connect with any PEP care throughout the city, as well as setting up that follow-up testing. If there is ongoing risk for contracting HIV, then there's that PEP to PrEP linkage. So once someone completes their post-exposure prophylaxis or the treatment for the amount of time that they needed, then we discuss going on PrEP, or the one pill once a day or one injection every 2 months for prevention of HIV.
And how early can someone see an HIV provider?
Yeah, so at Thrive, really we'll be able to connect we have, as I said, a large group of providers. We'll be able to get people very soon, within 1 to 2 weeks, especially if they have new diagnoses. We do focus a lot on rapid starting, or what we call rapid starting treatment as early as possible. If people are moving from a clinic from another clinic, there's always a way to get into some of our clinics. That being said, I'll say that Jacques also does an excellent job in making sure you are seen very soon, and to make sure that you have access to the medications you need.
Great. I think those were all the questions. Thank you.
Yeah, thank you so much. Thank you again for organizing this for another year, and happy Pride Month.
Yeah.